Well, good morning, everyone. I'm Dr. Laura Lachert, and welcome to today's Medical Grand Rounds. I am so excited for today's session. Per usual, we'll get started with some reminders, some logistics, and then get into introductions for today's presentation. Please be sure to join us next week. We are hosting the very special annual Clavin Lectureship. This will be available only virtually, so be sure to join us on Teams Live next week. We will be hosting Dr. Richard Hoffman. He's Emeritus Professor of Internal Medicine at the University of Iowa and also co-leader of the Cancer Epidemiology Population Science Program. And he will be giving an enlightening talk on prostate cancer screening, an evolving area that I think will be useful to all of us. So please be sure to join us virtually next week for the Clavin Lectureship. And just a reminder that Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Center. We're often here live in person at Souther Auditorium at St. Vincent on Tuesday mornings at 8 a.m. We are sometimes available live at Providence Portland at noon on Tuesdays. You can always find us at this time on Teams Live, and you can know how it's going to be by the weekly Grand Rounds invite. We'll let you know if we are in person or not. Regardless, you can earn CME credit by being live in the room, by watching virtual live, or by watching a recording of the event. And similarly, that recording is available at the same link as the Grand Rounds invite each week. I'll be monitoring the Q&A during today's session. So for those of you online, feel free to pop up your questions, and I will field those at the end of each speaker. And now on to plans and introductions for today. One of my favorite Grand Rounds today are several of our residents from the Providence St. Vincent Internal Medicine Residency Program will be sharing their work that they have prepared to present at the Oregon chapter of the American College of Physicians meeting, which is happening here in Portland this year, later this week. If you're able to join us for the academic meeting and or the poster session, which occurs Thursday evening, there is a website and QR link available, Oregon ACP. I am so inspired by the work that these physicians have put together. Much in quality improvement, some of the most interesting cases that they have done the hard work of caring for in the hospital throughout the academic year so far. I am going to let each of them individually introduce themselves as they come up to the podium. And thank you to our chief resident, Adriana Morse, who has helped lead this effort. All right. Let's do it.
Okay. All right, we'll start with Christina.
Okay, hey everyone, I'm Christina Patel. I'm a third year resident at St. Vincent's Internal Medicine Residency Program, and I'm excited to talk about my quality improvement project that's not just about improving healthcare, it's about making life easier for everyone involved. That includes our patients, our providers, and yes, even hospital administrators trying to balance the books. I'm going to show a simple but impactful initiative using an electronic medical tool to improve communication among the healthcare team in an effort to reduce length of stay for hospitalized patients. Let's start with some background information. So in 2023, there were 34 million hospitalizations in the US, and the average length of stay was 4.5 days. This adds up to billions of dollars spent in the healthcare system, which is why hospital administrators are focused on timely discharges. In 2022, at Providence St. Vincent's, The estimated date of discharge electronic tool, or EDD tool, was introduced to standardize communication among the medical team. This tool asks providers to predict when a patient will be discharged and to flag any medical barriers that might get in the way of that. It can be seen in Figure 1 of the poster. However, getting hospitalists and residents to use this new tool consistently can be challenging just with their busy schedules. That's where my project came in. We wanted to increase the use of the EDD tool without adding more stress to our providers. Our target was to increase EDD tool utilization among residents from 60 to 75%, with the goal of improving communication and leading to reduced length of stay and getting our patients home faster. So here's how we did it. We ran a controlled before and after study with the internal medicine residents and hospitalists as the control group. Both groups had access to the EDD tool and embedded in their patient notes. But here's where we add a little spice. For residents, we introduced quarterly pauses, and not just any pauses. Think gratitude cards, public recognition on Instagram, and a healthy dose of appreciation. Yes, the residents really like the Instagram shout out, so you can see on the poster. Hospitalists, on the other hand, got a more traditional, albeit undisclosed, financial incentive as a group. We measured 3 key things. 1, EDD tool utilization, 2nd, length of stay, and the 3rd was adjusted length of stay, which takes into account how sick an individual patient is. We wanted to see if our approach of combining incentives and positive reinforcement actually made a difference with EDD tool use. So the results, EDD tool use actually skyrocketed for both groups, as you can see in the top graph. But here's the plot twist. Residents' utilization was much more consistent and reliable post-intervention, as you can see with the smaller confidence interval. So why was that? Maybe because we celebrated the residents. The quarterly pauses, the Instagram shout-outs, the personalized thank yous, those little boost of recognition really made an impact. And we saw this shift toward a culture of communication that's now just a part of the residents' daily routine. Did we see a massive drop in length of stay? Well, not exactly. The results were not statistically significant, likely because discharge processes are complex and influenced by a bunch of factors in itself. But the exciting part is we did reduce length of stay by 0.4 days for about 2,500 resident patients, and that saves about 1,000 hospital days over the course of the year that the study was done. So what does all this mean? Well, in simple terms, by improving communication through a simple electronic tool and showing our providers some love, we've taken a big step toward reducing length of stay, which can save both time and money for the hospitalized, for the healthcare system. And it didn't require much expenses and a complicated overhaul, just a little recognition, a touch of technology, and some good old-fashioned teamwork. So in conclusion, the project shows that sometimes the most powerful improvements come from the simplest ideas. And when you mix a little appreciation in, big change can happen. Thank you.
Fabulous. Any questions for Dr. Patel? Great. I think it's simple enough. It speaks for itself. Thank you, Dr. Patel.
Hello, I'm Job Ashby, 2nd-year resident, and I will be telling you the secret of the sputum. So this is a case report that was on one of the awards months I did. So for some context, ofatumumab is a self-administered CD20 human monoclonal antibody therapy for relapsing forms of multiple sclerosis. In general, biologic therapies carry an increased risk of serious infections, including atypical pneumonias. Legionellosis is rarely associated with anti-CD420 agents. And I have a case for you of a young man taking ofatumumab for his MS who developed Legionella pneumoniae pneumonia. So to get right into it, the case report. We have a 30-year-old man with MS diagnosed 2 years prior, stable on ofatumumab, presenting with fevers, cough, hemoptysis. A week earlier, he developed these symptoms after administering his ofatumumab, consistent with his prior injection reactions. However, the symptoms lingered. So he presented, his vitals were found to be normal. He appeared ill and clammy on exam with bilateral pulmonary bronchi. Labs were notable for a mild leukocytosis and procalcitonin elevation. A chest radiograph below showed extensive opacification of the left upper and lower lobes, and he was treated initially with ceftriaxone and azithromycin. It was later broadened to piperacillin tazobactam after he developed a fever of 40.3 Celsius. And his sputum cultures, Legionella and Streptococcus pneumonia urine antigen testing all returned negative initially. He became hypoxemic after several days, and a computed tomography scan was obtained showing diffuse ground glass opacities. His bronchoscopy, later performed, showed just a positive Legionella nuclear amplification antibody test, and his sputum cultures remained negative. He was treated with a 5-day course of levofloxacin and discharged home breathing room air. So we have on the bottom his initial chest x-ray, where you can see 4 days later his CT scan on the other side of the poster actually has on the axial cut some right-sided opacifications developing. So on the initial therapy, his Legionella was worsening. The teaching point from this case is that the Legionella urine antigen testing that we initially performed and said, you know what, with this negative testing, we don't think he has Legionella, has pretty good sensitivity, 69 to 100%, and very good specificity, 99 to 100%. And this urine antigen testing is used in 97% of clinical diagnosis of Legionella, but it's only specific for serogroup 1. Serogroup 1 accounts for 50 to 80% of Legionella infections. So if you use only urine antigen testing, you could be missing 20 to 50% of Legionella infections. And even if it is serogroup 1, 8% of patients with Legionnaire's disease have no antigen in their urine at all. So with this case, our patient's young age may lead you to believe he does not have an atypical infection when he presents, but due to his his CD20 usage, he was at risk. This is odd because while immunologics like alemtuzumab in various case reports do have associations with Legionella, it's not very common with CD20 agents, which is more like rituximab. To date, there's been no case reports of Legionella pneumonia associated with ofatumumab, this being the first case report. So while exceedingly rare in young patients with immunosuppression with anti-CD20 monoclonal antibodies, presenting with pneumonia, Legionellosis should remain on your differential until it's definitively ruled out by bronchoscopy, as the urine antigen testing is not useful. So, thank you.
Great. Any questions for Dr. Ashby? I think while the audience ponders, can you remind us, Dr. Ashby, the importance of the diagnosis, specifically what changes in the antibiotics?
Yeah, so part of the issue with this case that led to his hypoxemia and worsening pneumonia was he was treated initially with the ceftriaxone azithromycin. He only received about 2 days of azithromycin before his Legionella urine antigen test returned negative, and we discontinued it. So he was, in fact, on inappropriate antibiotic therapy until we had the definitive diagnosis.
Thank you. Perfect. We will move on to our next presenter. Thank you so much.
Hello, everybody. My name is Kemen. I'm a third-year resident at Providence St. Vincent. Today, I'm sharing with you our project on implementing community-acquired pneumonia pathway to reduce IV antibiotic length of stay in patients who are hospitalized with uncomplicated pneumonia, which I will now refer to as CAP. CAP is a very common and costly diagnosis in the US, and it contributes to over 1.5 million hospitalizations with an annual cost of approximately $7.7 billion. Our study specifically aimed to reduce length of stay and the duration of IV antibiotics for patients with uncomplicated CAP at a tertiary teaching hospital, and this was modeled after a successful randomized control trial by Karatala and his colleagues. During our daily multidisciplinary rounds, resident teams along with inpatient pharmacists worked together to identify patients that were eligible to switch from IV to oral antibiotics. To qualify for de-escalation, patients needed to meet specific criteria, which included stable vital signs and tolerating oral intake. You can see the de-escalation criteria on the left in a blue box. We also excluded immunosuppressed patients. We conducted a before and after analysis comparing the 12-month intervention period to the 12 months prior. In total, this included 59 cases before the intervention and 74 cases after intervention. Our analysis revealed that there was no significant difference in the median number of days on IV antibiotics between the two groups. The pre-intervention group patients spent a median of 2.9 days, while post-intervention was reduced slightly to 2.7 days. This is graphically shown in Figure 1. As for length of stay, the median decreased from 3.8 to 3.3 days, which again was not statistically significant and shown in Figure 2. The box and whisker plots also depict our confidence intervals, which you can see there is some overlap, but the trend was an overall decrease in both primary measures. It is also important to note that we examined patient demographics in respect to our primary outcome measures, but had too small of a sample to draw any conclusions here. Looking at the median length of stay analysis again, our total length of stay reduction did translate to an approximate 37 hospital days that were avoided over the course of 1 year. In comparison to Karatala et al.'s pathway, our hospital already had a relatively low length of stay and IV antibiotic duration. And this suggests that there may be a limit to further reducing IV therapy, and it may not be prudent without risking patient safety. Now looking ahead, we hope to expand our CAP pathway by integrating the IV to oral transition into the sepsis order set for non-severe CAP cases. This would utilize nurse-driven vital sign parameters, similar to what was used in this project to help identify patients that would qualify for oral antibiotics. I thank you for your attention, and I welcome any questions you may have.
Many thanks, Dr. Fina. Any questions here in the room?
Thanks so much for this project. I'm just wondering, in the Karatala article, what kind of reduction did they see?
Yeah, so Karatala et al. Had reported a median length of stay 3.9 days versus 6.0 days before their intervention in a usual care group. And then as far as length of stay on IV antibiotics, so they had 4 days on IV antibiotics prior to their intervention compared to 2. So significant difference compared to ours.
Thanks so much. I love your plans for next steps. Fantastic to see. I was curious to how important you thought the participation of pharmacy was in the success of your project.
I think that with any project, multidisciplinary approach is really important. It helped to kind of gain motivation and drive. And we actually always round with our pharmacists, so helping them feel included, I think, was also an important component.
Thanks, Dr. Fina. We'll take our next speaker.
Good morning, everybody. My name is Amanda. I'm a third-year resident, and today I'll be presenting my QI project on increasing the use of SGLT2 inhibitors in patients with type 2 diabetes and chronic kidney disease. So chronic kidney disease, also known as CKD, affects 26 million people in the United States and is a significant long-term complication of diabetes. approximately 50% of patients with type 2 diabetes and 33% of patients with type 1 diabetes will develop CKD. And there are medications that can be given to help reduce this progression to end-stage renal disease. Historically, the mainstay of treatment for this has focused on giving patients ACE inhibitors or ARBs. But new guidelines from the American Diabetes Association, as shown here, actually recommend starting an SGLT2 inhibitor in these patients who are already on a maximally tolerated dose of an ACE inhibitor or ARB. And these recommendations are supported from data from landmark trials such as DAPA-CKD, which looked at dapagliflozin use, and EMPA-KIDNEY, which looked at empagliflozin use. And both of these studies demonstrated that SGLT2 inhibitors significantly reduce the risk of CKD progression to ESRD in patients both with and without diabetes. And also something to note is that in the DAPA-CKD study, the number needed to treat to prevent one primary outcome event was 19, with the primary outcome events including a composite of a sustained decline in eGFR of at least 50%, ESRD, or death from renal or cardiovascular causes. So in our project, we aimed to increase the number of patients at the Providence primary care group at St. Vincent who are taking SGLT2 inhibitors who have type 2 diabetes and chronic kidney disease. So what we did is we conducted a database query in our clinic to identify adult patients with CKD and type 2 diabetes who were not on an SGLT2 inhibitor. We identified those patients with active MyChart accounts, and we sent them a MyChart message shown here. And this letter was sent in both English and Spanish. I also educated residents and faculty on this intervention and informed them why starting an SGLT2 inhibitor can be beneficial in this patient population. So in total, 100 patients received the MyChart message, of which 98 were English speaking and 2 were Spanish speaking. Of the 98 English speaking patients, 81 patients scheduled an appointment, and 10 patients ended up starting an SGLT2 inhibitor, with 2 starting an ACE inhibitor or ARB. In the Spanish-speaking population, although 2 patients received the message, both of them did not read it. However, 1 patient was able to schedule an appointment to discuss this further with their PCP. So overall, this quality improvement project successfully increased the number of patients on SGLT2 inhibitors with a simple yet low-cost intervention of a single MyChart message. This single MyChart message potentially changed the course of care for approximately 13% of patients who were eligible to receive the MyChart message. And we may have potentially prevented their progression of CKD to end-stage renal disease. Preventing the progression to end-stage renal disease is very important for patients and can also help reduce their healthcare costs. For example, the average yearly cost of hemodialysis for a patient on Medicare is $108,000 per year, which is approximately $3,300 per month. So in summary, our results suggest that electronic outreach methods such as MyChart messaging may be helpful in optimizing renal protective therapy in patients with diabetes and could also decrease their healthcare expenditures.
Great, thank you. Any questions from the room for Dr. Tepp?
Dr. Tepp, thank you for this. And it's inspiring to me that such an easy thing could make such a difference. As you've thought about the project, have you thought about what you would do next if a MyChart message only worked for 13% of folks? Any other ideas percolating?
Yeah, it's a good question. So next steps could potentially be to develop some kind of workflow to reach out to patients who weren't captured initially. For example, we have 20 patients here who didn't read the MyChart message in English. So that could be a possibility. Other ways could be maybe to make like flyers or things like that to post in the clinic, and then also calling patients.
This is amazing. And just to follow up on what Shelley said, I wonder if Tom or anybody knows what the disease management team workflow is and whether or not they use anything besides MyChart and whether or not they would consider this an important enough quality measure that they would actually include it in their work.
We actually didn't have a chance to talk to them about that, so I appreciate Dr. Chow's input. If you have anything.
Yeah, thank you for that question. So the disease management team's workflow is right now just sort of a first level cut at making sure that patients with diabetes get their A1Cs and yearly screening for urine microalbumin and EGFR. So that's a prerequisite step to determining whether a patient would qualify for an SGLT2 inhibitor. However, they do not go into further steps, and they rarely make phone calls. Yes. Unfortunately, that's I think due to the fact that they have it's a relatively small group that's taking care of like all of Providence Medical Group.
Thank you, Dr. Tapp. We have a question posted online. You might not be done with you yet, Dr. Tapp. Was cost a barrier to adding an SGLT2?
Thank you for that question. So cost was a big thing that we factored in this project. We actually discovered from doing this project and talking to the pharmacist in our clinic is that Medicaid actually pays for most of the SGLT2 inhibitor, but Medicare doesn't always pay for all of it. So in some discussions with patients, cost actually was a barrier and was a reason why some patients didn't start it, but at least we were able to get 10 patients on it. So moving forward, maybe we could also incorporate like resources for payment options or things like that to include the patients when we talk to them about this.
Thank you, Dr. Tapp. It is great to know that it is fully covered for some of our most vulnerable patients. Really important information. Thank you.
Thanks.
Good morning, everybody. My name is Lynn Taylor. I am a second-year resident at Providence St. Vincent. And today I am bringing to you the study result from my quality improvement project titled Sepsis Transitional Care Management. Could a phone call change a life? Sepsis is a topic that does not need an introduction. The only background information I'd like to bring forward is the fact that we know there is racial disparity in sepsis care outcome. Specifically at Providence, Oregon 8 Regional Hospital, Black sepsis patients have a readmissions rate higher than that of their white counterparts at 12.9% for Black sepsis patients versus 11.6% for our white patients. And through our literature study, we know that transitional care management does make a difference in reducing readmissions rate for sepsis patients. With that in mind, in this project, I'm going to try to use this. The purpose of this project is to reduce readmissions rate for Black sepsis patients at 8 Regional Providence Hospital from 12.9 to 11.6% to match that of our white sepsis patients' counterparts. To go into the project, first we started with some data analysis. I want to point your attention to figure 1. This is a simplified version of our root cause analysis looking at why our Black sepsis patients get readmitted at a higher rate than our white patients. The disparity happens, and by reviewing data and pulling records, we know that 2/3 of our Black sepsis patients who get readmitted are those who do not have Providence Medical Group PCP. So these are primary care physicians who belong to Providence Medical Group will be abbreviated as PMG in this poster, and therefore they do not get the transitional care management service or phone call from Providence. Understanding that, and by going further, by talking to patients, doing focus group as illustrated in Figure 2, a sample from our graphic novel for sepsis education, illustrating those focus group activities, and by re-interviewing our transitional care management team, we developed our own transitional care management workflow. As a first-year internal medicine resident, I worked with our sepsis care coordinator, registered nurse, and our faculty attending, who is a Providence Health Equity Fellow, to develop our own workflow, pulling data, and started outreach to patients from December of 2023 to June of 2024. During this time, we continue solving problem about how to get patients in for PCP for follow-up if they don't have a primary care provider or if they don't know how to do their own outreach. We provide sepsis education on these phone calls. And in June 2024, we did data review and plan for more patients focus group. The result was very interesting. And I call your attention to Figure 2. As you recall, our project focused specifically on Black non-PMG patient, illustrated in the orange color. On the x-axis is 14-day follow-up rates, and on the y-axis is timeline. Bottom is our pre-data, and post is and higher up is our post data. The PMG patients, so the ones who do get the Providence Transitional Care Management workflow, they have a follow-up rate in the pre-period of 85%, and the pre-period for our non-PMG patient was 29%. In our post-period, that 29% follow-up rate for non-PMG patient increased to 33%. So this is a 5% increase in 14 days follow-up rate. And there is a caveat to this data. Our data is unable to pull follow-up appointments or visit made that do not get pulled into EPIC. So our true follow-up rate for non-PMG Black patients may actually be higher than this. Regardless, by looking at this data, the most striking learning point for us is that there is still, even though our workflow did improve the quality improvement rate for the Black non-PMG patient, there is still quite a gap in the follow-up rate for our non-PMG versus non-PMG patients, and there is more to do there. Then going on, still looking at the specific group that got our interventions, the non-PMG group, I call your attention to Figure 4. On the x-axis is our timeline, divided into pre-period and post-period for each non-PMG, which is in the orange color line, and PMG for the blue color line. And the y-axis is the readmissions rate. This data breaks down for us. Looking at the non-PMG readmissions rate, we know that with the pre-period, they get readmitted at around 16%, and that readmissions rate did drop to 15% in the post-period. However, the biggest learning point in reviewing this data is the variation we get month by month for this patient population. For example, we take a look at one of the outlier in one of the pre-period right here. There was 4 readmissions for Blacks non-PMG sepsis patient that month, and that was a readmissions rate of 70%. This happens because in the Providence 8 Regional Hospital, our Black patients population is low. That leads to a lot of variations in our data. Some months, the readmissions rate could be a lot higher than the others, and it doesn't mean, and some months they will be lower. It doesn't mean that our patients are not vulnerable, but this is just one of the drawbacks of doing quality improvement work, and we have to kind of learn from that. And that leads me to another point about doing this kind of work. health equity work is extremely challenging because of such variation. And that's why we place quite a bit of value, not just looking at our quantitative data, but also our qualitative data, what our patients tell us, what we get from focus group, and going along learning from this project. With that, I call your attention to figure 5. And this is when we look further, not just at the specific patients population, the non-PMG Black patients that we served, but the entire Black and white patient populations at Providence 8 regional hospitals. On the x-axis is our timeline during the timeline of the project, and the y-axis is 14 days follow-up rate. And the most striking learning point in this graph is the data point in March of 2023 when we were doing interventions. There is a significant drop in our follow-up rate this month. Usually we look at about 21 or 18 or 20 or 14 follow-ups for our Black sepsis patients in Providence, Oregon, but this month it's dropped to 11. The interesting thing about the month of March is that I was an intern in our ICU working 6 days a week. And our sepsis coordinator registered nurse was on a mission trip, not available to do interventions to reach out. And we see a correlated drop in follow-up rate. This tells me that our intervention does make a difference. And looking further broad, going back to our original aim of this quality improvement project, readmissions rate, we ultimately did see a reduction in readmissions for our both PMG and non-PMG patients, and the readmissions rate dropped to 12.9%. So this project was done over 6 months. We learned quite a bit. We did see that we do make a difference in follow-up rate for the patients' populations that we specifically target. We learned that because of the nature of health equity quality improvement work, we can't really trust data overall because there are more nuance to it, and the fact that we have a smaller sample size, it is challenging to get to truly clinically significant data. However, we did see that transitional care management could increase follow-up rate and therefore reduce readmissions and potentially reduce mortality. And most importantly, we learned that our vulnerable patients could benefit from this, and that qualitative learning from working with these patients' populations is just as important as our quantitative learning. And to quote something that comes from our focus group and talking to patients, 4 of our patients spontaneously brought up the value of primary care provider relationships. I don't trust many people, but I trust her. In this case, it's their primary care provider. I have known her for 25 years. And with that, I am hopeful that we'll continue this work. Our phase 2 has been launched for other vulnerable patient populations. We have medical students joining us from all different stages of training. And that shows not just that our health system understand the value of this work, but also our future physicians understand the value and the future of this work. And with that, I will take any questions.
Thanks, Len. I'm wondering if from your data or perhaps other data, you have an idea of what's driving these readmissions. Is it recurrence of sepsis? Is it worsening of chronic diseases? Is it problems with getting medications, et cetera?
Yes, and I think the answer is a lot of all of the above. And the most important thing is never has anything to do with their race or ethnicity. It is always the other drivers that is a surrogate marker that cluster around race and ethnicity that lead to these readmissions. Might that be not understanding the need to continue taking antibiotics, not being able to get into follow-up with their PCP? And I think I would defer to Dr. Sanders to advise more if there is more specific answer to Dr. Haynos. Yeah.
Thanks. We have one question from online. Perhaps highlighting the success of your work, we note that in parallel, readmissions increased among white patients, though not the focus of your work. Any insights into why readmissions went up overall?
Yes. So I think interesting part in our data as well. And I think this may reflect more of a system trend that happened during these 6 months that the project carried out, because we would usually consider that a balancing measure, because one problem in QI work is you do good work to help a population and you can do counter good work, so bad work for the other population. I don't think in this case that is what happens, but it's just simply the way the data, the way patients get admitted during those 6 months.
Great. I think we will move on to our next presenter. Thank you, Dr. Taylor.
Right, last but not least is Dr. Townsend. All right. Okay, so I'm Julia. I'm one of this is a case presentation for kind of a rarer disease that we often don't see, that we saw in the words earlier this year. So this is a case of a 72-year-old male, has a past medical history, dermatitis herpetiformis, gout, and iron deficiency. Is that better? Cool. Maybe I'll just a little short. So, yeah. So he takes metoprolol, iron, allopurinol, colchicine, and dapsone at home. The last thing for his dermatitis herpetiformis, and he ended up undergoing an elective lumbar interbody fusion of his plates L3 and 4, and then was having some post-op hypoxia. So he had his elective procedure and then had some post-op hypoxia that ultimately led into the evening, and our team was consulted the next morning to kind of evaluate this refractory hypoxia. When we went to go see him, he was fairly anxious, but didn't look like he had any increased work of breathing, and his lung sounds were normal. His physical exam was otherwise unremarkable. We got obviously basic labs, which were also fairly unremarkable. And then we have his ABG up there in the in the table, and overall didn't look that abnormal. His pH is a little bit high, and his PO2 was 99%. When we saw him, he was on 100% FiO2 heated high flow with his pulse ox reading in the mid to high 80s. They had gotten a chest x-ray overnight, which didn't show anything remarkable. We ended up getting a CT angio to rule out any PE, which was also negative. And we got an echo to evaluate his heart function, which was normal. Added on a bubble study to look for any kind of shunting, because throughout the day he remained on 100% heated high flow, sitting in the 80s. With all this workup being negative, we ended up kind of starting to go back to the drawing board and thinking about more rare diseases. And something that really stood out to us was the fact that he's on dapsone, which is a medication that we often don't see. He also got IV lidocaine during his procedure, and both of these are medications that can be associated with acquired methemoglobinemia, along with the fact that he has this saturation gap where his pulse ox is reading in the mid 80s, but his ABG shows oxygen saturation of 99%. Both of these things kind of made us worried about methemoglobinemia. So we checked a methemoglobin and it was elevated at 12.5%. With no other reason for his hypoxia, we decided to treat it with methylene blue. And within 30 minutes of treatment, he ended up off heated high flow, sitting really well on just several liters nasal cannula, which was really cool to see. I think I wanted to highlight this case just because it is a really great example of a rare pathophysiology and kind of some rarer causes. So the most common cause of acquired methemoglobinemia is medications, dapsone being number 1, and then topical anesthetics, so benzocaine, lidocaine being number 2. It also highlights kind of the classic findings. So one of which is anxiety, actually. The next is hypoxia that's refractory to supplemental oxygen. And then the saturation gap, which I highlighted, where the pulse ox is lower than the ABG oxygen saturation. In summary, methemoglobinemia is a diagnosis of exclusion and requires a high degree of suspicion to test for it. And this case really highlights the importance of taking a good history and then kind of going back to the drawing board, thinking about more rarer diagnoses when your initial workup is negative or doesn't really fit how the patient is presenting. That's it. Any questions?
Great, thank you. What questions do we have for Dr. Townsend? I'll start with one, which reveals I haven't thought about pathophysiology for a while. Can you remind us, particularly with the mismatch between the pulse ox and then the ABG, is methemoglobin effective at all in delivering oxygen to the tissues? And how much do we clinically have to worry about that low sat on the pulse ox?
Yeah, so it is. So yes, it does decrease oxygen delivery to the tissues, mainly because the methemoglobin cannot bind to oxygen. So when you get to higher and higher percentages of methemoglobin in the body, then you do decrease the amount of oxygen that's going to the tissues.
Our patient was right to be anxious.
Yeah.
Just curious how fast that methemoglobin level came back.
It was actually really pretty fast, like maybe an hour or so.
And
yeah.
Okay, I was curious, like if you would have kind of empirically treated with methylene blue, if you didn't have that value, if you guys were still pretty suspicious for that.
Yeah. So that's a good question. I guess we didn't really think about doing that because he wasn't getting any worse, I guess. And so we had time to wait. But the one thing about methylene blue is that if someone has like a G6PD deficiency, then it can actually make the methemoglobinemia worse. Because he was on dapsone, we didn't feel like we needed to check for that because I think dapsone is contraindicated for that as well, and he'd been on that for many years. So that's like kind of the only caveat when thinking about just preeminently treating it. Yeah.
Fantastic. Thank you so much, Dr. Townsend. Just a few last reminders. So this is a teaser for their great work at Oregon ACP later this week, Thursday and Friday. It is not too late to sign up for the meeting. Also, be sure to join us next week for Grand Rounds. We'll be hosting our annual Clavin Lectureship featuring prostate cancer screening from an invited speaker. That is available only virtually, so join us online next week. Let's have one last round of applause for our fantastic internal medicine residents.